Welcome to our influenza review for USMLE Step 2. In this video, we will master the pathophysiology of antigenic shift versus drift, diagnosis, antiviral treatment, the major complications including pneumonia, and the influenza vaccine including its contraindications. Let's get started. Influenza is caused by influenza viruses, with types A and B being the most clinically important. Type C causes only mild illness. Transmission is person to person via respiratory droplets, which is why outbreaks spread rapidly in schools, nursing homes, and hospitals. The virus has two key surface antigens. Hemagglutinin, abbreviated H, allows the virus to enter host cells by binding to sialic acid receptors. Neuraminidase, abbreviated N, allows the release of newly made viruses from infected cells. Influenza typically peaks in winter months. Step 2 Pearl. Neuraminidase is the target of oseltamivir, which is why these drugs are called neuraminidase inhibitors. They block viral release. There are two ways influenza changes genetically, and the distinction is high yield for Step 2. Antigenic shift involves reassortment of genome segments when two different subtypes infect the same cell. This causes a major sudden change in the virus, producing a new subtype to which the population has no immunity. Antigenic shift causes pandemics and occurs only in influenza A. Antigenic drift involves point mutations in the hemagglutinin or neuraminidase genes. This causes minor, gradual changes in the antigens. Drift causes epidemics, which are seasonal outbreaks limited to a specific region or population. Drift can occur in both influenza A and B. Mnemonic to remember: shift causes pandemics. Drift causes epidemics. Big change equals big spread. The classic influenza presentation is the sudden onset of systemic symptoms combined with respiratory symptoms. Systemic features include high fever with chills, headache, prominent myalgia and arthralgia, fatigue, and malaise. Respiratory features include a dry cough, sore throat, nasal congestion, and acute bronchitis. The hallmark is how rapidly the symptoms appear, typically within hours. Step 2 Pearl. Influenza is distinguished from the common cold by the suddenness and severity of systemic symptoms. A common cold develops gradually and is milder. A patient who tells you they were fine in the morning and felt terrible by evening with high fever and body aches has the flu. For diagnosis, two main tests are used. RT-PCR is the gold standard. It has both high sensitivity and high specificity, can distinguish influenza A from B, and results return within hours. The rapid antigen test has high specificity, but lower sensitivity. It gives a result in 15 to 30 minutes, making it useful at the point of care. But a negative result does not rule out influenza. Step 2 Pearl. During flu season, the diagnosis is often clinical based on classic symptoms in an exposed patient. Testing is most useful for hospitalized patients, immunocompromised patients, and those who would benefit from antiviral therapy. The mainstay of treatment is neuraminidase inhibitors, which work best within 48 hours of symptom onset. The most commonly used agent is oseltamivir, sold as Tamiflu, which is given orally. Zanamivir is an inhaled neuraminidase inhibitor that should be avoided in asthma and COPD because it can cause bronchospasm. Baloxavir is an oral single-dose option that works by a different mechanism, inhibiting CAP-dependent endonuclease. Step 2 Pearl. Treat all hospitalized patients, all high-risk patients, and consider treatment for healthy patients within 48 hours of symptom onset. The benefit is reduction in symptom duration and complications. Certain patients are at higher risk for influenza complications and should be prioritized for treatment and vaccination. These include adults 65 years and older, children under 5 with the highest risk under age 2, pregnant women, and those within 2 weeks postpartum. Patients with chronic conditions like asthma, COPD, heart disease, or diabetes, immunocompromised patients, residents of nursing homes and long-term care facilities, and patients with a BMI of 40 or more. Step 2 Pearl. These high-risk patients should receive antivirals regardless of when symptoms started, even if they present after the typical 48-hour window. The benefit still outweighs the risk because their mortality from influenza is so much higher. Primary influenza pneumonia is a direct viral pneumonia where the virus invades the lung parenchyma itself. The course is rapidly progressive and severe. The pattern on imaging often shows diffuse hemorrhagic pneumonia. It may progress to acute respiratory distress syndrome, or ARDS, and multi-organ failure. Prognosis is poor with high mortality. Treatment requires aggressive supportive care and intravenous antivirals. Step 2 Pearl. A patient with influenza who develops worsening hypoxemia and bilateral pulmonary infiltrates within days of symptom onset should raise concern for primary influenza pneumonia progressing to ARDS. Post-influenza bacterial pneumonia is even more commonly tested. The classic vignette is a patient with influenza who initially starts to improve, then suddenly worsens with new fever and purulent cough. The most common causative pathogens are Streptococcus pneumoniae, which is the most frequent, Staphylococcus aureus including MRSA, Streptococcus pyogenes, and Haemophilus influenzae. Post-influenza Staph aureus pneumonia has classic features: hyperacute onset, severe hypoxemia and cyanosis, hemoptysis, and importantly, cavitations or pneumatocysts on chest X-ray. Step 2 Pearl. The classic vignette is a patient who recovers from flu, then develops recurrent fever, purulent sputum, and cavitary lung lesions. Think post-influenza Staph aureus pneumonia. Empirically cover for MRSA with vancomycin or linezolid. There are two main types of influenza vaccine. The inactivated influenza vaccine, abbreviated IIV, is given intramuscularly. It is approved for everyone 6 months of age or older. A high-dose version exists for those 65 and older to improve immune response. It is safe in pregnancy and in immunocompromised patients. The live attenuated influenza vaccine, abbreviated LAIV, is given as an intranasal spray. It is approved only for ages 2 to 49 and is contraindicated in pregnancy, immunocompromised patients, and adults 50 and older. Step 2 Pearl. Annual vaccination is recommended for everyone 6 months and older. The ideal time to vaccinate is September or October, before flu season peaks. Vaccine contraindications are commonly tested. Absolute contraindications for all influenza vaccines include anaphylaxis to a prior flu vaccine, severe allergy to any vaccine component, and Guillain-Barré syndrome occurring within 6 weeks of a prior flu vaccine. Importantly, egg allergy is not a contraindication for any influenza vaccine, even though most vaccines are egg-based. For pregnancy, the inactivated vaccine is strongly recommended at any trimester. The live attenuated vaccine is contraindicated. Influenza during pregnancy increases the risk of preterm delivery, spontaneous abortion, and congenital defects. Maternal antibodies also protect the newborn for the first 6 months. Step 2 Pearl. Egg allergy is not a contraindication for influenza vaccination. This is a classic test trap. Let's wrap up. Pathophysiology. Antigenic shift involves reassortment and causes pandemics. Antigenic drift involves point mutations and causes epidemics. Hemagglutinin mediates entry, and neuraminidase mediates release, which is why neuraminidase inhibitors block the spread of the virus. Clinical features: sudden onset of high fever, chills, myalgia, headache, malaise, plus a dry cough and sore throat. Diagnosis: RT-PCR is the gold standard. Rapid antigen testing is fast but less sensitive. During flu season, diagnosis is often clinical. Treatment: oseltamivir, zanamivir, or baloxavir, ideally within 48 hours of symptom onset. Treat all hospitalized and high-risk patients regardless of timing. Complications: primary influenza pneumonia can progress to ARDS. Post-influenza bacterial pneumonia is most commonly caused by Streptococcus pneumoniae and Staphylococcus aureus, with cavitations and pneumatocysts suggesting Staph aureus. Vaccination: annual inactivated vaccine for everyone 6 months and older, ideally in September or October. Pregnancy gets inactivated, not live attenuated. Finally, the classic Step 2 traps. Shift equals pandemic. Drift equals epidemic. Post-influenza cavitary pneumonia equals Staph aureus. Egg allergy is not a contraindication. LAIV is for ages 2 to 49 only, never in pregnancy. Good luck on your exam.